All right. Hi, everyone who is coming on in. We're just going to give people a few minutes to pop on through, but welcome back to our third month of Cheers with Peers. This is a special Elektra Health event where we speak with experts in the field of menopause, reviewing a case study. And this month we are really excited to kind of take a special angle on cognitive and cognitive health through the menopause transition. And to help us, walk through this case and to help us understand a little bit more about the newest research coming up. And truly, this is very, cutting edge stuff. We are, like hot off the presses kind of research studies that we're going to be talking about today. So I'm really excited. For those of you who don't know me, there may be some new folks here. My name is Jackie Gianelli. I am Elektra Health's founding nurse practitioner. I am, certified by the North American Menopause Society, and I am so excited to be here with you guys. And just to, kind of cut to the chase, our special guest is Dr. Lila Nachtigall. And I will read her a very amazing bio to you guys. She is one of the world's leading reproductive endocrinologists, widely recognized for pioneering medical research on hormone therapy, estrogen, and menopause. She has authored over 500 articles in medical journals, 3 books, lectured all over the world in the field of women's health. She is currently a professor at NYU, and she has served as one of the past presidents of the North American Menopause Society and many other, accolades. I could go on and on and on. So we are very excited to have Dr. Nachtigall here. So welcome, Dr. Nachtigall.
Thank you.
You're welcome. So with that said, I know that cognitive health during the menopause transition is something that when I was learning about menopause, something that wasn't, I would say, as accessible as some of the other information. So, we are not, like Dr. Nachtigall and I talked about this a little bit, and we are not, really taught a lot of this in school in general. And also a lot of the literature is not easy enough for us to access because some of it is actually in journals of neurology. And so that kind of speaks to this siloed part of menopause where menopause affects all the body symptoms. And sometimes we study these symptoms and these body systems sort of separate from, the actual physiology of menopause itself. And so sometimes that kind of breaks it up into chunks that leave it sort of inaccessible to the providers who need to know it the most. So that's what we're really excited to dive into today. We'll get to the case study in just a moment. I am gonna, if you guys can see this poll, I'm gonna end the poll because that didn't work. Okay, we're gonna not do the poll anymore. I don't know how that happened, Laura. Let's relaunch it. We'll clear. All right, let's try it again. There we go. Can you guys see the poll? Yes? Okay. So good. All right. So this is kind of what I was alluding to. So let's do it quickly. We know that a younger age at menopause is associated with an increased risk. And so for women who go into menopause at a younger age, 41 to 46, what is their about approximate chance of developing Alzheimer's? Higher chance of developing Alzheimer's than women who hit menopause between 51 and 55. And just, if you're just completely guessing, just throw a number in there. I love a poll. All right. So any other answers? Anyone? So it looks like the majority of folks said potentially 70%. The answer is actually the answer that no one chose, which is 29%, which is still a great, a pretty significant increase when we're talking about increased risk from earlier onset of menopause. All right, so I'm going to end that. And all right, so for the next part of our presentation, I just want to move this out of the way. All right, let us, I think, get into, I think the way we thought that we would do this is, since this is a little bit novel for some of us, we wanted to let Dr. Nachtigall kind of move through some educational slides, kind of talking about some of the research. And then when we're done, and when we're feeling a little bit more educated about it, we'll go into the case study that you guys had access to before we started this presentation. And then we can talk a little bit about how we would approach this patient. Because this patient is very similar to a lot of the patients we're going to see. It's actually a real patient, de-identified completely. And so this is a pretty, common case. And I think this will be helpful for us in clinical practice. So Lila, I don't know if you can see the slides that are up, but I will move through them for you as we talk. Does that sound good?
Sounds good.
Awesome.
Ready to go.
Go ahead.
I'm showing this first because the WHI did a very poor job of deciding during their study about the issue of the beginning of dementia. They took all the over 65-year-old women, they gave them a quiz at start and at 1 year after either estrogen therapy or placebo. And then they reported that the women on estrogen at the year didn't do as well on this non-validated questionnaire. And they said it may mean that they headed toward dementia. And from this little bit of not good information on every single package insert, as all of you know who've ever prescribed estrogen, it says women over 65, because of the WHI study, may have a tendency on estrogen to increase dementia. I think that's the scariest sentence on the whole package insert. And then they let that go. And now, we're 22 years from the original WHI. We have had almost 200 follow-up articles from the WHI itself, and they never get published in the newspapers or in our journals. But anyway, this is the 18-year follow-up of the WHI where they have mortality statistics. They actually did postmortems on anyone who died. And sure enough, on the estrogen alone issue versus placebo, the Alzheimer's or dementia mortality was decreased by 25%. And even the conjugate estrogen plus the MPA versus placebo had a perception of decrease, although it wasn't statistically significant, but the estrogen alone was. When they pooled all the estrogen, it was statistically significant and decreased in both dementia and Alzheimer's by 15%. So I think that should have been changed long ago because their own study showed that, and they're very resistant to change it. But I think you should know that. And we do know from the next slide that this wonderful study, which is called the Cash County study, it's really the only long-term, very validated questionnaire where they used the mini mental status, which has been validated for all age groups. And what they had the much older age group. They had two divisions, 65 to 74 and 75 and older. And in both those older age groups of the over 65 women, when they compared women over 15 years of taking estrogen, which is amazing that they have that, they always did better than women who were never on hormones, a good bit better. And over the 15 years, they never decreased their mini mental status, which is a great sign in both age groups. So again, even if we don't want to say that estrogen looks preventive of cognition loss, we certainly can say the estrogen does not increase dementia in any way. And I think that's incredibly important. And I have to say, next slide, it makes me feel that
You can just nod at me.
not enough time has passed. Anyway, this is a recent European study, and they call it menopausal hormone therapy now in Europe, MHT. And again, they showed very clearly women on estrogen for 1 year or women never on estrogen were no different. Not a surprise. But then if women were on estrogen 2 years or more, continually, amazingly statistically significant, 0.0001, they went down dramatically in their clinical brain impairment, which is called mild clinical impairment or the beginning of dementia. They went from 33% non-treated down to 8 to 12%, very significant, and even on for more than 15 years, they stayed down at that level. So clearly they were wrong on the original MCI. So there's no way I can advance this. I'll have to take the time to ask for it. So that brings us what I really wanted to share with you tonight. And that is all the new information about Alzheimer's disease. And as Jackie indicated, so much of this research has been in the neurologic field, which I can understand, but we need to know it. We need to know what happens with hormones, and we actually have to fight to get this out. So we've known for a long time that women get Alzheimer's more than men. And it actually, all over the world, when you look at the ratio, it's 2-to-1 women to men. And I think originally they said, well, women live longer, so maybe that's why. But it clearly is not that. And it clearly is hormonal, if I can see the next slide. And this is dramatic. Again, we know this. We know that men make testosterone well into their 80s, even into the 90s. And we know that testosterone metabolizes to estrogen. So this is the male estrogen, and this is the female estrogen, which comes crashing down at menopause. We know that. We know all the things that happen because of it. And because of that, if we look at the average 70-year-old woman and the average 70-year-old man, the male has twice as much estrogen as the woman. And that may actually be part of why they are protected from Alzheimer's and women aren't. We'll get the next slide in. And this is what the neurologists have been talking about for a while. I think we all know about tau protein. I think we never paid big attention to it in early studies. It's a disorganized, very flexible protein. It's resistant to high temperatures. It's resistant to acid. But importantly, it's one of the most soluble proteins. And one of the things that have been developed in the neuro research is that many neurodegenerative diseases, which they call tauopathies, are abnormal phosphorylated forms of tau protein, which aggregate in filaments. And a very important point is that phosphorylated tau is not soluble. And so it forms this neurofibrillatory tangle. I mean, it looks like twisted ribbons, and those are very permanent, and they are what form within the brain cells, and they are really what cause the decrease in cognition, continual and getting worse and worse in Alzheimer's. And the tau protein becomes pathological with its modification, particularly phosphorylation and hyperphosphorylation. Sorry. And this was a really elaborate and amazing study, again, done many years ago, was only reported in neurochemistry, and maybe we didn't pay enough attention to it. But showing that you can suppress this phosphorylation and phosphorylation with estrogen. Even if you use a substance that increases the phosphorylation, if you add estrogen, you can decrease it. And they show this with immunostaining. And if we see the next slide, it goes into the fact that 17 beta estradiol clearly in aging women can forestall the onset of Alzheimer's. Amazing, because we have nothing else so far that does it. And in all the investigation, it could work before these fibrous tangles were formed by phosphorylated tau protein. And it actually inhibited that phosphorylation. Who's changing slides? I can't signal them. So here's the deal. When the cells were pre-treated with estradiol for 24 hours, the overexpression of the PS214, which is a precursor, failed to induce any hyperphosphorylation at the sites that were pre-treated with estradiol. And the same results were shown as I showed you on that picture of the immunofluorescence. The same thing. You could prevent the phosphorylation. And this data confirmed that you could actually prevent tau from this bad event that caused the tangles with estradiol. And may I have the next one? So here we go. Here's why I feel very excited by this. We know Alzheimer's is a disorder we cannot treat so far. We've tried lots of things. They've even approved a drug that doesn't seem to work at all. But any disease that we can't treat, we should prevent. I think that's all we can do. And we know now that phosphorylation of tau protein makes permanent, non-soluble tangles in the brain that lead to continual decreased cognition. We know now that estrogen can prevent phosphorylation of the tau protein and prevent the formation of these tangles. And we did see both in the WHI and in the KEEP study that estrogen given early on was preventive of cognition loss. So we also know that if you can get estrogen in before the phosphorylation that occurs in Alzheimer's, you can actually prevent Alzheimer's disease. And we have nothing else that does it. And I say, definitely not in my lifetime will the FDA allow us to say we can use this to prevent Alzheimer's. But I think we have to know that it can, and we have to do it early. And what we have to do is better screening for women who are high risk at Alzheimer's. And so to get them early enough, once that phosphorylation and those tangles are there, we can't get rid of them. So I think this is a very exciting issue, and we present a very real and recent case.
Yeah, so thank you. That was really, I think, a great summation of kind of what we know now. And I think a few things are, super interesting. I mean, one is that we know this information is coming up and coming out, and yet the FDA, is still so stuck on this data from 20 years ago that these package inserts get branded with these terrible, like you said, awful, scary labels. And yet we have so much evidence to the contrary now. So I think we as clinicians while it's not going to be ever, and at least like, not in the next few years, FDA approved, we have to take it upon ourselves to let our patients know that that's sort of old news and here's the new news, right? This is where it's on us. And unfortunately, when you're not supported by your FDA, you have to take that initiative. You have to do your homework. You have to be the one to advocate for your patients, because certainly if this information isn't accessible to us, even that easily as clinicians, how would our patients ever get to it? And so your patients will thank you, in 20 years or whenever the FDA decides to come to, and they realize how, important this would have been. And the other thing is, and I see this a lot in my clinical practice now in New York, but a lot of my patients are, it's sort of controversial, but getting some of this genetic testing to see whether or not they're going to be more predisposed, based on their genetics, this ApoE4 testing that people are doing. And there's, some conflict about it, because it's like, well, like Lila said, like we don't like necessarily have a treatment for once you get Alzheimer's. We have not figured that out. And so that can be very scary to know that you're destined for something potentially that has no treatment. But the reality is that there's so much we can do to prevent it. Estrogen being one option, certainly there are other things too. And so is that, in the right patient with the right sort of consent, is that something that we have to have these conversations about? And I think it is, because if, we're not bringing it up, our patients are going to, ask us about it. And so I think it's important to be educated. So those are a couple of things that came to mind as you were speaking. Does anybody have questions about the research or the data that was presented? If so, now's a great time to ask. If not, we can dive into this case, and always, feel free to come off mute and raise your hand, or just like, this is a safe space to talk. So if anyone, wants to just chime on in now, feel free. Otherwise, the chat is there for your questions and we will get to them for sure at the end. So I don't see anything. So I will assume everyone is good with this. So let's hop on now to this case. So this is again, a de-identified patient, a 54-year-old Caucasian female, G2P2. She presents to your menopause clinic with severe hot flashes, difficulty sleeping, mood changes, right? Pretty classic menopausal stuff. Her last period was 5 months ago. So not fully postmenopausal yet, but certainly, getting close, especially at 54, very regular periods previously. We do her blood work. We see an FSH of 88, a low estradiol, normal thyroid, normal chemistries, no major medical problems, hospitalizations, except for her usual, the usual reproductive stuff. This is a patient who did have genetic testing done at age 45, probably because she had some significant family history, and found to be heterozygous for the ApoE4 gene. So I'll let Dr. Nachtigall talk a little bit too about that gene and how, because there's actually a few different forms of it. And so what does it mean to be heterozygous versus, something else? And when someone finds out, that they do have the gene, what do they want to think about? But her family history is significant for Alzheimer's on her maternal side. And there's also a history of some stroke and cardiovascular disease, I believe. So she comes, and she previously, a couple months ago, had been prescribed estrogen for these symptoms of menopause that we discussed. But she, like a lot of our patients do, she read the package insert. It's like you can read the package insert. And it is said, like we mentioned, that women over 65 are going to be at increased risk of probable dementia, with estrogen versus placebo. And everyone says, oh, I'm not taking this. So how do you approach this patient? What are some things that you might, say? How would you counsel her, knowing what you know now about, estrogen and its role in cognition in menopause? And I will encourage you guys to throw some answers in the chat. Anything goes. Anyone? Well, no one has any thoughts. I will let Dr. Nachtigall talk you through how she managed this patient. Why don't you throw some pearls of wisdom our way?
First, I have to say that up until a few years ago, I didn't even recommend that people get genetic testing, even if they were high risk, because I thought how terrible to live with that. We have nothing to offer them, and they walk around like waiting for the shoe to fall. And I think that's really why we're talking about this tonight. It's a new ball game. You do want to find the genetics because we really feel, especially this woman at 54 and no sign of it yet, which is very fortunate. Um, it looks like she still could get some prevention. It's interesting because she's a candidate for estrogen anyway, because she has severe hot flush. I think she had 30 a day and couldn't sleep at all and had real mood changes. And interestingly, I mean, she really had a family history. Her mother and her maternal grandmother both had full-blown Alzheimer's. Her grandmother got it at age 60 and her mother at age 57. And her mother died of stroke at age 62. But the incidence of stroke and Alzheimer's is higher than in the general population. So there must be some relation to the plaque formation in the brain that can lead to that. And we know with all genetics, if her grandmother was 60, her mother was 57, she's getting there. So it did help that her daughter is a physician. And her daughter was one who discussed with her that the package insert may not be accurate. It's based on something else. And it was over 65 and it was on a screening test, and these people didn't have the gene. And actually showed her mother some of the tau protein information about phosphorylation. So I think we do have what happened after that, do we? Or we would just, do we have a next slide?
Is there a next slide? I think this
No,
was.
maybe we didn't give the final answer. It was for everybody else to figure out. But the final answer was between the daughter and myself, we talked her into going on estrogen. And the really interesting thing was, I mean, she loved not having flushes and being able to sleep and feeling she was herself again. That she said, even if it wasn't for the issue of the Alzheimer's, you know, she would stay on it. And I think that's something we all see, that some doctor may, or they read the package insert, or a doctor says, oh, I don't use estrogen anymore because the WHO said don't, or whatever. And, you know, and if they don't get relief, it's so unfair to go through a bad quality of life. Well, anyway, she's very happy with it. I think we're going to prevent her from getting Alzheimer's on this estrogen, but she recently told me that she's never going off in any way. So I hope we'll be able to follow her and see that she never does get the.
So I have a question from the audience that is more of sort of a like kind of what is your sort of like personal opinion on this? And so in this person, you know, they're asking, because of what you mentioned about, you know, the potential of 2+ years of HRT on, you know, preventing mild cognitive impairment, say for somebody with a personal history of estrogen receptor positive breast cancer, who say like had, you know, surgery and had a mastectomy, and, you know, you're always worried about a recurrence. And obviously we know that that is a, you know, sort of currently a contraindication to HRT. But when we're talking about sort of the paternalistic aspect of medicine and just sort of saying like, this is a hard no for you, rather than saying like, these are the risks, these are the benefits, in that scenario, you know, what is sort of the risk benefit of somebody who like might have a significant family history of Alzheimer's disease and wants to try to use HRT for a couple of years after a bilateral mastectomy, after like, say like DCIS or something, you know, or some ER positive breast cancer? How would you kind of think about that?
Well, that is a big issue. And because breast cancer is so common, um, and I really handle each case individually. I gave a seminar a couple of weeks ago where I gave 4 cases of breast cancer and reasons for going on estrogen. And the answer was different in all the cases.
Mm.
So your one case where, say, she had DCIS and maybe she took both breasts off and it's been a couple of years and she's fine, and you get an MRI of her chest because she has no breasts, and nothing is there. I mean, you're sure she has a couple of breast cells. One of the things we learned from the WHI that nobody ever writes in the newspapers for the lay population, if you take estrogen without daily progestin, so get the benefit of estrogen, it was Premarin in this case, it actually decreased the incidence against placebo of breast cancer. And what we really know is estrogen does not take a normal breast cell and make it malignant ever.
Mhm.
What they're worried about is that this woman has left, any of the breast cancer women, has left a pre-malignant or even a malignant cell that's quiet, a breast cell that's abnormal. And if it's estrogen receptor positive cells sitting there, obviously, if you give estrogen, you're going to make it grow. So really what you're doing in all these breast cancer cases is weighing just what you said, Jackie, the risks and the benefits. And if she needs estrogen for a benefit, what you need to know, is it likely that she has any estrogen receptor positive abnormal breast cells that might turn more malignant or grow with estrogen? And that's what you have to do. So a woman who hasn't had her breast off, who is one that you could follow very carefully with mammography. It is very good at, at looking at growth of cells. If she has some of the really bad cells like the HEU or the HER positive, that would be a woman I would probably try not to give estrogen to.
Mm.
If she has the BRCA1 gene, which almost always, if it leads to breast cancer, leads to estrogen receptor negative breast cancer, I am generous with those women, and they never say that. They always say, if you've had breast cancer, you can't take estrogen. That isn't really what the correct answer is.
Mhm.
So you individualize that. If this woman post breast cancer had a positive APOE4, which we really know dramatically leads to Alzheimer's, I would think until we get something better, I would like her to be on estrogen and watching her breasts carefully.
Yeah, thank you for being, I think, like honest about the realities of this, because you're right. Most people, it's just like, sorry, you've had breast cancer. And I think women are starting to realize that there are nuances around that based on the types, like you said, the types of breast cancer, what you've chosen to do about the breast cancer, and some of your other risk factors that we are learning about more and more about every day, but certainly aren't, as widely understood or known, APOE4 gene being one of them. So I certainly think too, cardiovascular risk, right? That's another sort of thing that versus breast cancer, right? And we know that there's many ways that estrogen is protective. What would be your opinion about, we always say with menopausal hormone therapy that it needs to be within, you need to start it within 10 years of your final period. Is that would, like, in terms of prevention of these, the tau phosphorylation and the plaque formation, is 10 years too much, or is it like one of those things that we should be starting this in like late perimenopause? Like what's the right window of time in terms of prevention for this plaque formation?
It's very clear that it makes a difference if you're too many years past estrogen. Things change. Your clotting factors definitely get worse. And we did see that where you can prevent heart disease, if you treat women within, say, 8 years of their last period, you definitely do. But once it's more than 10, you actually are negative on the heart issues. And I think the same is true for the prevention here of cognitive decline, that you're definitely better off on the early side. And your point is 10 years too much? I think you're getting close to being a problem if it's really 10 years. So, under 10, we're really safe. We use under 8. And certainly for the cognitive changes, not the ones that are really true Alzheimer's with these real tangles that you can't do anything about. But we know that we get these early changes in the brain. Women call it brain fog, but it's clearly in the noun area, in the hippocampus. And we see that now on MRIs. We can actually pinpoint that the hippocampus is affected early. And if you don't treat early, and I would say really in that case, within 5 years, you do kill off the brain cells and leading to beginning with mild cognitive impairment, but definitely this deficiency where you cannot find the word. You can't find the noun particularly. You see the face, you know who the person is, but you can't get the name. And that's because that's stored in the hippocampus.
Could you talk a little bit about brain fog and kind of like why it happens and whether it's linked to diseases like Alzheimer's and whether or not HRT helps with brain fog?
We don't think it's linked to Alzheimer's because they haven't found any of the tau deficient phosphorylation problems or what they call the tau pathologies in that when they look. But they have found decreased blood flow to the hippocampal area particularly, which is what people mean by brain fog, I think. And that's a blood flow issue that's definitely from estrogen deficiency. We can see it dramatically, particularly in really early menopause in the first 3 to 5 years, 3 years particularly. Women come in and they say, I can't stand it. I can't do nouns. I can't find words. And that's blood flow to the hippocampus. You give estrogen within weeks, you see the increased blood flow. And particularly women who are having hot flushes, each hot flash, while they're occurring, they've done PET scans since the 80s and seen this, that during the hot flash, the cerebral blood flow all over is markedly decreased. Even though it's only for 3 minutes at a time, it's occurring all day and it's really depleting the blood supply.
Interesting. Well, it's 8:41 and we have a few minutes left. So if anyone else wants to come off and ask any questions, and it doesn't have to be, it could be about cognitive health, but it could be about anything. We talked a little bit about breast cancer tonight. Dr. Nachtigall knows a lot about a lot of things about menopause, so I'm sure she'd be happy to answer anyone's questions. So do not be shy. And you can just pop it right in the chat. But yeah, I think, this is something that is so important to talk about. It is something that we need to get the word out about, because I think, dementia is one of the hardest sort of, saddest, toughest things for people to go through. It's hard to see your loved one, lose their ability to mentate, and that affects families. And it really is something that if we can prevent, we can learn more about. And the fact, it's so interesting, that whole statistic in that graph with the hormones, with where you see that actually men who are, compared to age matched to women, have more estrogen floating around. And yet, women, it's like, oh, I'm not taking that estrogen. And it's like, your husband has more estrogen than you do. And no one's talking about that, and how that might be, interestingly, how that might be benefiting them. So I think that's just such a striking point. And Laura also asks, you may have addressed this, but ApoE testing, is that now standard of care for people with family history of Alzheimer's disease? Is that where we are with testing, or is it something you have to sort of advocate for?
I think it's becoming, it isn't standard of care, but it's certainly becoming. Anyone who has a history like this, no problem, people will recommend they get tested. It does definitely run in families, but when you see it in a grandmother and a mother, a grandfather and a father, a grandmother and a father, and etc., 2 generations, the new generation should definitely get it. And as I said, maybe it wasn't fair to have it when you didn't think you could do anything. This is the first thing that you can really do early in prevention.
Somebody also asked about progesterone, and does that have any impact on, tau proteins or the brain in terms of cognition and dementia?
So far, there's only one very small study with progestin looking at the phosphorylation, and the progestin does not seem to suppress it, but it doesn't increase it. But that will have to be looked at. At least it's not a negative.
At least it's not a negative, right? Right. And testosterone, we probably know nothing about, right?
We don't have any studies, but my guess is it would be beneficial. It would be preventative, because all testosterone, whether you take it exogenously or you make it endogenously, converts to estrogen. It's how it's excreted. So you do get estrogen from testosterone. I would definitely think it prevents phosphorylation. And I think the reason men are more protected is that they make their testosterone for so much longer.
Mm-hmm. Yeah.
I always think that menopause is a biologic accident. It just happens we make estrogen from the ovaries, and the ovaries can only work for somewhere around 45 to 55 years. And we weren't meant to live past there, I think.
Yeah, it's an interesting thing to think about, from a long-term perspective. And I just want to thank you, because we're out of time. It's 8:45, and this has been great. I think I learned so much from this conversation and just from reading these articles, and I know that's going to change the way that I practice. And I think these little pearls, these nuggets of information that I think my patients will want to know about. And so I really appreciate your wisdom here and your time and helping us put together this case. And for everyone here, thank you for joining us. You can always email your questions to us afterwards. We will be happy, to get back to you. And Elektra Health is a resource for your patients. We have been putting together a fun little Slack channel. This is something that we use in digital health. So if you're not familiar with it, it's kind of like just a private channel with which you can network with other clinicians. So I encourage everybody there's a link in the chat. So if you guys want to join, it's totally free. And it's just a safe space for us to talk about de-identified patient cases like this one, where, you might see a patient and be like, I don't know, what do I do? And now, you can bring that to us and to your colleagues, and we can talk about it in sort of a safe, private space. And you can also, professionally network. And I just think it's, it's about time that we, as clinicians really support each other. And so this is one way that we're hoping to do that. So again, thank you so much, Dr. Nachtigall. Thank you everyone for joining us, and stay tuned for the next one. Have a good night.